And I have the distinct pleasure to introduce our next speaker for Cardiology II, who is a friend of mine, Dr. Karen McConnell. Dr. McConnell is the Clinical Director in Innovative Delivery Solutions and a cardiology subject matter expert for Cardinal Health. She is a fellow of ACCP. She has taught in the prep course, in the AmCare prep course, and now in the Pharmacotherapy prep course since 2011. And she has received multiple teaching awards. She's won a Best Paper Award from the Cardiology PRN. She is a mom of two very active boys, and so she does it all. We are in for a treat, and she is going to focus on the chronic care aspect of cardiology. And with that, I'm turning it over to Dr. McConnell.
Thank you, Dr. Finks. It's such a pleasure to be here at the Pharmacotherapy prep course. Like Dr. Finks said, I have taught in AmCare since 2011. I worked in an AmCare cardiology clinic for several years at Kaiser Permanente in Colorado. Just recently went into the corporate world, which is definitely different, but I still get to use my cardiology expertise there, so it's kind of the best of both worlds. So I have no conflicts of interest to disclose. And today we're going to talk about chronic disease state management of these cardiology comorbid conditions. So we're going to talk about chronic heart failure. We'll talk about the treatment plan and monitoring plan for patients with atrial fibrillation. We'll talk about hypertension. We'll talk about risk assessment in patients with ASCVD. And finally, we'll round out with lipid therapy, most specifically with intensity of statin therapy. I did want to let you all know that we're not going to talk about the chronic management of coronary heart disease simply for the sake of time, but it is covered in your chapter, and so all of that information is very nicely laid out at the end of that chapter. So now let's go ahead and dive into heart failure. And we're going to start out with a case, because this is really why we do this, right? It's for the patients, and when you do ambulatory care, you really get to know your patients. And so we have Liz. She's a 48-year-old female, and she's had a rough life, but now she has a 2-year-old granddaughter, and so she has decided to turn around her life, and she really wants some help with her heart failure. So she has alcohol-induced heart failure, and her ejection fraction is 20%, and she has symptoms of dyspnea and fatigue. Today her blood pressure is 112/70, and her heart rate is 68 beats per minute. You can see there her medication. She's on lisinopril, furosemide, carvedilol, spironolactone, and digoxin. So what I'm going to do is I'm going to ask you a question, we're going to go over some content, and then we're going to bring back the question. So I'd love to see you guys answer the question now, and then we'll see if your answer changes once we come back to the case. So which of the following is the best approach to maximize her management of heart failure? Should we increase her carvedilol to 25 milligrams twice a day, increase her lisinopril to 40 milligrams a day, increase her spironolactone to 50 milligrams a day, or should we increase her digoxin dose? So what do you guys think? I see some reds and some blues. So we have a little bit of a mixed crowd, so let's see what we should do. So heart failure is a very complex clinical syndrome, and it's caused by structural or functional cardiac disorder that impairs the ability of the ventricle to fill and eject blood. So you can just imagine the ventricle, and in most patients, it's pumping and it's doing its job and it's getting the blood out to the body. But in patients with heart failure, it's just not able to do that, and that causes lots of symptoms in patients. And there's two types of heart failure. The one that we're most familiar with is heart failure with reduced ejection fraction, or HFrEF. And it's previously known as systolic failure. And it's the one that we're going to focus most on in this presentation because we have the most data on how we can prevent morbidity and mortality in these patients. But it's really important to know there's also HFpEF, and that's heart failure with preserved ejection fraction, not preferred, that's be preserved. And it's previously known as diastolic heart failure. So for HFrEF, the ejection fraction is less than 40%. Patients have impaired wall motion and they have a dilated ventricle. Most of the time, HFrEF is caused by coronary heart disease. But about a third of the time, it's attributable to other reasons, including alcohol, chemotherapeutic agents, myocarditis, tachycardia, or patients who had just had a baby and they experience systolic dysfunction. So what are the goals of patients with HFrEF? First, we want to modify and control the risk factors. And then we want to block the compensatory neurohormonal activation that causes further deterioration. We want to prevent or minimize sodium and water retention, eliminate or minimize symptoms of heart failure, slow the progression of the dysfunction, and of course, we want to decrease morbidity and mortality. A lot of these patients are very sick. They're frequent flyers to the hospital, so we want to keep them out of the hospital as much as we can. So this table is really important to understand when you're taking the test because patients are referred both by their stages, A, B, C, and D, as well as their functional class. So it's really important to understand what the difference between the two are. So the stages really tell you if a patient has structural heart disease and if they have symptoms or ever had symptoms. And that's really important to remember because what patients look like today and versus what they look like in the past may be completely different, but their stage of heart failure does not change. So really stage A is patients who may be at high risk for heart failure but don't have it. And so you probably won't see that referred to much. Stage B are people who have structural heart disease but do not have signs or symptoms. Again, so that's maybe someone who's post-MI but never had any symptoms of heart failure. Probably won't see that stage a lot either when you're talking about heart failure patients. Most of the patients fall into stage C and D, structural heart disease with prior or current symptoms. So it's important to know if they've ever had symptoms of heart failure, they'll stay in stage C. And then stage D is refractory heart failure requiring specialized interventions, and those are the sickest of the sick. Then you can see in the table that it also corresponds to their functional class. So if they're having symptoms, what symptoms are they and how severe they are? In A, they have no functional class. In B, they're asymptomatic. And then C, you can see they can be anywhere from 1 to 4. 1 is no limitation in symptoms. 2 is slight limitations. 3, marked limitations, meaning they're having some issues with their daily living activities. And 4, they have symptoms at rest. So no matter what they're doing, they're having symptoms. And everyone in stage D is in class 4. So now let's talk about heart failure therapies. So one of the mainstays in heart failure therapy is diuretics. And that's because a lot of these patients are volume overloaded, and they need those diuretics in order to achieve euvolemia. Diuretics have been shown to have short-term and intermediate-term benefits, but remember that they haven't demonstrated long-term benefits, meaning they've not been shown to have a direct effect on mortality. But they definitely make patients feel better because they decrease that peripheral edema, they decrease pulmonary congestion. They can also decrease their daily symptoms and just make them feel better by allowing the increase in exercise tolerance. The caveats to diuretic use. So generally we're not using them as monotherapy because they have not been shown to decrease mortality. So we want to make sure that patients are on medications that decrease mortality. You initiate them for volume overload and you adjust to about 1 to 2 pounds a day. You don't want to have a marked decrease in volume because that can make them very sick and make them have to go to the hospital. You want to make sure you adjust their chronic therapy to maintain euvolemia. So if they're already at euvolemia, you don't want to be messing with their diuretic therapy because that could either make them too dry or too wet. You can use combination therapy with diuretic therapy, but you need to do it with caution because that can really mess with their electrolytes. And so if you do need combination therapy, say a loop diuretic and a thiazide diuretic, you need to monitor them very closely, especially their electrolytes. Start with a low dose, and you can titrate as needed. So the loop diuretics are the medications that are the mainstay of therapy for heart failure. A lot of times we'll start with furosemide, and then if patients need a better absorption, especially in their gut, you can move to Bumex or torsemide. Ethacrynic acid is there for patients who have a true sulfonamide allergy. This one is pretty expensive, and so we want to make sure that this one's really needed if it's used. It also has a lot of ototoxicity, especially at higher doses. The thiazide diuretics, as we know, are really good for hypertension, but may not be as effective in treating volume overload. Metolazone is one that can be added to loop diuretics, but like I said previously, it needs to be done with caution. So ACE inhibitors, of course, are our mainstay of therapy when we're looking at heart failure. They work by blocking the production of angiotensin II. They decrease sympathetic stimulation. They decrease the production of aldosterone and vasopressin, and that results in a decrease in vasoconstriction. They also increase bradykinins, which increases vasodilatory prostaglandins and may affect myocardial remodeling. So if you have this question on the test, someone has an ejection fraction less than 40%, you can't find any contraindications in the case, and they're asking, should this patient be on an ACE inhibitor? Usually the answer is yes. ACE inhibitors have been shown to decrease mortality, they decrease hospitalizations, and they improve symptoms, and they make patients feel better. So these are really win-win medications for patients that are very well tolerated. So how do we dose these medications? You want to initiate at a low dose and titrate slowly over 1 to 4 weeks. And you want to titrate to the target dose for the greatest benefit. I'm going to show you a table in just a minute with all the target doses in it, but it's really important to know what the target doses are for many of the ACE inhibitors so that if you're asked on the exam, should a medication be changed, you'll know what that target is, and that will help you with the exam. It's also really important to monitor the serum creatinine. Oftentimes you'll see a transient increase in serum creatinine, and up to 30% is fine because it's really the kidneys adjusting to that mechanism of action. But if you see more than a 30% increase, you may want to decrease the dose back down and check it out, see if they have renal artery stenosis or some other reason why that creatinine is increasing. It's also important to monitor for signs and symptoms of hypotension. These medications that treat HFrEF oftentimes lower blood pressure, and sometimes we're fighting hypotension more often than we're fighting hypertension. So just be sure you monitor that very closely, and also monitor potassium, and use with caution if the potassium is over 5 milliequivalents per liter. And you want to check within 3 days of initiation. Important adverse effects for ACE inhibitors are cough. About 10% of patients do experience cough. And, it's a discussion with the patient. Can you tolerate the cough? And if the answer is no, we can switch to ARB therapy and have similar benefits, but usually without the cough. Angioedema is also another side effect that is very severe, and obviously we would discontinue the ACE inhibitor if someone experienced it. Switching to an ARB is definitely an area of debate. Some cardiologists say you can definitely switch, and if they have angioedema with that, you just discontinue it, but to let them have the benefits. Other cardiologists disagree and say we don't want to increase the risk of angioedema, we'll try other therapies. So if you do decide to do that, you want to make sure you do it with caution. So this is the table I was referring to a moment ago. This is the table with the target doses. So this is really important to remember. So just because a drug can be titrated, like lisinopril, the target dose is 20 milligrams a day. You could go up to 40, but that's not really the target dose for lisinopril. So I just mentioned ARBs, and those, like I said previously, have not been shown to be superior, but they are a reasonable alternative for patients who cannot tolerate ACE inhibitor therapy. Another issue in the guidelines is that if someone's already taking an ARB and they develop heart failure, you don't have to switch them to an ACE inhibitor. You can continue their current therapy. And the monitoring is the same. And here's the target doses for the ARBs in case the patient is on an ARB in your case. Now let's move to beta blockers. So beta blockers block the effect of norepinephrine and other sympathetic neurotransmitters on the heart and vascular system. And what that does, it decreases the incidence of ventricular arrhythmias that Dr. Fink talked about, decrease the cardiac hypertrophy and cardiac cell death, and decrease vasoconstriction and heart rate. So all of these things are very beneficial to patients with heart failure. If you choose carvedilol, it can also further decrease systemic vascular resistance, and it's also better at blood pressure reduction than metoprolol succinate, since it does have that additional alpha blockade. So if you have a patient with heart failure and their blood pressure is not well controlled and they're on metoprolol, you can consider switching them over to carvedilol. So when do we use beta blockers? So we want to initiate these when patients are stable. We don't want to initiate these in decompensated heart failure. But when they are used at optimal doses, they have been shown to decrease mortality, decrease hospitalizations, improve symptoms, and improve ejection fraction. So these also should be initiated in patients if they have an ejection fraction less than 40%, unless there's contraindications present. So you can add beta blockers to existing ACE inhibitor therapy. Again, you want to start low and increase slowly over time, usually about every 2 weeks. And patients will notice improvements over several months. So they may not start feeling better right away, but as their body adjusts to the beta blocker therapy, they'll start feeling better and better. Do remember there's only 3 beta blockers that are used in the United States for heart failure: bisoprolol, carvedilol, and metoprolol succinate. Those are the 3 that have the best evidence in use in heart failure. Again, you want to make sure you monitor blood pressure, and you also want to monitor heart rate. Some of these patients do get bradycardia quite easily, and if it becomes symptomatic, then we'll need to decrease the dose. Here are the target doses for beta blocker therapy. Again, very important to know these doses. Now let's go to aldosterone antagonists. So that's spironolactone and eplerenone. And they definitely now have a role in heart failure. And they work by decreasing the loss of potassium and magnesium, decreasing sodium retention, and eliminating catecholamine potentiation. Spironolactone is indicated for New York Heart Association class 3 or 4, and it has been shown to decrease mortality, hospitalizations, and improve symptoms. And eplerenone has been shown to do very similar effects as well. So the indications for these medications, so for patients who have a class 2 to 4 with an ejection fraction less than 35%, and they have a history, it's been shown to have a history of CV hospitalization or elevated BNP. They're also recommended in all patients with an acute MI or signs and symptoms of heart failure, diabetes, and they have an ejection fraction less than 40%. In those patient populations, that's when aldosterone antagonists have been shown to be most beneficial. Here's the dosing of the aldosterone antagonists, and you'll see that they're stratified according to the renal function. So for a creatinine clearance greater than 50 mils per minute and a potassium less than 5, eplerenone can be started at 25 milligrams a day, where you can see spironolactone has a range between 12.5 and 25 milligrams a day. And then the maintenance doses you'll see are listed there for both medications that you would increase the dose after 1 month. For patients who have impaired renal function, you want to start the doses lower because, again, it can have a very marked effect on potassium if they have impaired renal function. So you want to make sure that you're checking a potassium and serum creatinine within the first 2 to 3 days after initiation, and then again 7 days after starting therapy, and then monthly for the first 3 months. And that's because the potassium can rise rather quickly with these medications, and we don't want to increase the patient's risk of a ventricular arrhythmia because they have hyperkalemia. So it's really, really important to monitor these medications very closely. Also keep in mind that most of these patients will also be on an ACE inhibitor or an ARB, which can also increase potassium. So this needs to be monitored very, very closely. Another adverse effect is gynecomastia, and this is especially prevalent in patients on spironolactone, and it can be reported up to 10%, and oftentimes it's very painful. And so if you do have patients that are reporting gynecomastia, you can substitute eplerenone for spironolactone, and the patient will still receive benefit, but they're not as likely to have the side effect. It's a less than 1% side effect with eplerenone. So now let's talk about digoxin. So digoxin has been shown in studies many, many years ago to improve symptoms, exercise tolerance, and decrease hospitalization. But do remember the studies that were done with digoxin were done before we had the optimized therapies of ACE inhibitors and beta blockers. So while digoxin may help some people feel better, the evidence isn't quite as strong because it hasn't been studied in the advent of the optimized medical therapy. It works by decreasing the central sympathetic outflow and decreases the renal absorption of sodium and some increase in cardiac contractility. So when would you use digoxin? So you can consider it. It's obviously not a hard and fast rule. You can consider it in patients with an ejection fraction less than 40% and continue to have signs and symptoms of heart failure that are already on optimal ACE inhibitor and beta blocker therapy. For patients with heart failure, the dose of 0.125 milligrams is usually adequate, and titrating the dose generally doesn't have any additional benefit. And if you do increase the dose, you can increase the risk of toxicity, especially in patients who have renal dysfunction, that are elderly, or they already have low potassium or magnesium. You want to monitor their renal function, and you want to make sure their serum concentration remains below 1 nanogram per mil. Hydralazine isosorbide is a combination of medications that is used sometimes in patients who are either African American or who cannot tolerate ACE inhibitor or ARB therapy. They both work to reduce, or hydralazine works to reduce afterload, and isosorbide works to reduce preload. So again, the two places in therapy for these medications, they have been shown to reduce morbidity and mortality in patients with African American descent, and they can also be useful in patients who are unable to tolerate an ACE or an ARB. In the studies, they've been shown to decrease mortality as well as decrease hospitalization. So now let's go back to Liz. Remember, she's the one that kind of had a rough life, but now she is taking control of her life, stopped drinking, but her ejection fraction still remains 20%. You can see her medications there: lisinopril, furosemide, carvedilol, spironolactone, and digoxin. So which of the following is the best approach to the management of her heart failure? Should we increase her carvedilol to 25 milligrams twice a day, increase her lisinopril to 40 milligrams a day, increase her spironolactone to 50 milligrams a day, or increase her digoxin to 0.25 milligrams a day? So I see mostly blue, and I would agree. I would increase her carvedilol to 25 milligrams twice a day. Her blood pressure and her heart rate will tolerate it. That will put her at the optimum dose for that beta blocker. She's already on lisinopril 20 milligrams a day, and that's the target dose, so that's probably sufficient. Increasing the spironolactone is a possibility, but we may not do that if because her blood pressure is already systolic 112. We're going to titrate her carvedilol, which can have a pretty marked effect on her blood pressure, and so we don't want to not get to the maximum or the target dose of beta blocker because we increase the aldosterone antagonist. And as you guys know, spironolactone can be very good at lowering blood pressure. And finally, we don't need to increase her digoxin. She's already on 0.125 milligrams, which is the heart failure dose. So there's a new medication. The brand name is Entresto, and it was just improved in 2015. It has not yet been incorporated into the heart failure guidelines. Those were last published in 2013. And so we're not really sure exactly where they're going to fit in, but this medication is intended to replace ACE inhibitor or ARB monotherapy. You'll see valsartan is in this medication, and so obviously we would not use this medication with one of those medications. It does have outcomes data to support its use. It did decrease the composite endpoint of death from cardiovascular causes or hospitalization by about 20%, and it also decreased all-cause mortality. And so it'll be very interesting to see once the next heart failure guidelines come out exactly where the place in therapy of this medication is. I was at the ACC meeting last weekend, and it definitely is a controversial topic, mostly due to its cost. So it's really important to not only focus on drug therapy in these patients, but also look at non-pharmacologic therapy. And you'll see throughout my talk today that there's a theme, if you will, for treating all of these medications or all of these disease states and what the non-pharmacologic therapy should be. We definitely want to prevent further cardiac injury. Patients should stop smoking. They should lose weight. They should control their hypertension. They should control their diabetes. I'm sure if you guys are in ambulatory care, you say these things all the time. They should minimize their alcohol, and they should limit their sodium. Now, the sodium limits are definitely up for debate. Some people think it's just not reasonable to expect someone to have a sodium level of less than 1,500 milligrams a day. So even if we could just decrease their sodium intake by 1,000 milligrams, wherever they are now, decrease by 1,000, then that could actually have some important impacts for them. Also, if patients have hyponatremia, reducing their fluid intake to 1.5 to 2 liters a day can be important for them as well. A moderate exercise program does have benefits. You'll definitely want to see where they are with their New York Heart Association class symptoms to see what they can do for exercise, but any movement is good if they can do it. You want to make sure they're appropriately vaccinated. You want to monitor and appropriately replace the electrolytes as needed, monitor for thyroid diseases, and of course, we want to screen and treat depression. So now we have Jim. He is an active farmer, but he was slowed down about 3 years ago from a myocardial infarction, and now he has New York Heart Association Class II heart failure. He has hypertension, depression, He does have some renal insufficiencies. And you can see his medication, as well as PVD. You can see his medications there. He's on quite the slew of medications. A lot of these patients take so many medications because they have a lot of comorbid conditions. So it's really important to screen their medications for appropriateness. You can see there his blood pressure, his heart rate. His labs are good except for his renal function, as well as his thyroid. So right now his HFrEF is stable. So which one of these medications might be adversely affecting his cardiac prognosis? Acetaminophen, sertraline, cilostazol, or levothyroxine? All right, I see a few C's. So this is a list of medications that patients should probably avoid if they have HFrEF. It's a very long list. Number one on the list is NSAIDs, which are available over the counter. And so these medications affect prostaglandins, and so that can definitely adversely affect patients with heart failure. And also, NSAIDs can increase your risk for hypertension, and hypertension also is not good for patients who have heart failure. Corticosteroids are often used, especially in patients with lung diseases or other immunocompromised diseases. Metformin you need to use with caution. Cilostazol is there on the list. Hormonal therapies, a lot of the antiarrhythmic drugs we can't use for patients with heart failure. So it's very, very important to know this list, because if you have a patient with heart failure and they're on these medications, they're most likely doing more harm than good. So as we said, cilostazol is definitely on the list. It's a PDE3 inhibitor, and drugs in that class have been shown to increase mortality in patients with heart failure. Acetaminophen is generally considered safe for these patients, as is sertraline. And of course, the patient had hypothyroidism, so we do want to treat him and make sure his TSH level remains in the normal range. So now I'm just going to briefly touch on HFpEF. So that, again, is heart failure with preserved ejection fraction. And it's defined as patients who have heart failure symptoms, but they have an ejection fraction greater than 50%. And this accounts for about 30% of patients with heart failure. So it's not an insignificant amount of patients. And it's caused by impaired ventricular relaxation and filling, and it's usually caused by hypertension. So this is one of the really great reasons why, if you see a patient with hypertension, that you treat them to goal. So in general, the treatment strategies for patients with HFpEF is we want to control their blood pressure, we want to control their heart rate, we want to control any volume issues they might have, and we want to manage any ischemia they might have. The pharmacologic therapy that's listed has not been shown to decrease morbidity in these patients, so do remember that. But if we are controlling their blood pressure, it's good to use an ACE inhibitor or an ARB. If they are having heart rate issues, you can consider digoxin or a beta blocker. And then the aldosterone antagonists were just studied in last year in a trial called TopCat, and they did show to decrease hospitalizations. So do keep in mind these medications if you're treating HFpEF. So for the key points, HFrEF is an ejection fraction less than 40%. The key medications are ACE inhibitors, beta blockers, and spironolactone, or eplerenone if patients don't tolerate Spiro. Start the ACE inhibitor first, and then titrate the dose of beta blocker. And these medications have been shown to improve morbidity and mortality. Add on diuretics if needed for fluid overload. And for HFpEF, which is injection fraction greater than 50%, you can use the same medications, but they may not affect mortality. Okay, now let's shift gears and go to atrial fibrillation. So now we have Paul. Paul is our workaholic. He's 52 years old, and he has a history of hypertension. And 2 years ago, he had a TIA. Did not slow him down. He still works about 60 hours a week. Several weeks ago, he started feeling a fluttering feeling in his chest on occasion over the past several weeks. It took him several weeks to come in because he just doesn't have time to go to the doctor. Currently for his hypertension, he's on metoprolol tartrate, 50 milligrams twice a day, and all of his labs are normal. His blood pressure is 130/78, and his heart rate is 76 beats per minute. And you can see there by the EKG, because we're all experts at reading EKGs, right? Well, I always ask the EP to tell me what it says, and he told me it's irregular rhythm, which means it's atrial fibrillation as well, and the no P waves can also clue us into that. So we'll talk about Paul now, and then we'll bring him back after a few slides. So just curious what you guys think. What is the most appropriate approach to manage his AFib? Should we begin digoxin? Should we begin diltiazem? Should we start warfarin, or should we start dabigatran? Anyone? Okay, well, I see a rainbow of colors, so clearly let's cover this. So atrial fibrillation affects 2 to 5 million patients in the United States, and it's associated with increased aging and chronic heart disease. So we're all going to get older, and heart disease is the #1 killer in the United States. So we see a lot of atrial fibrillation for those patients who do survive their first MI. It's frequently seen with comorbidities, and atrial fibrillation complicates the management of the comorbidities, and comorbidities complicate the management of atrial fibrillation. So when you put it in the mix, it really makes things harder to manage the patient. It is associated with stroke, heart failure, and death. So it's really important to remember that we manage atrial fibrillation appropriately. And where the death comes from is from thromboembolism. So atrial fibrillation itself, if patients are adequately anticoagulated, will not cause someone to die. It's not one of those fatal arrhythmias, but it can cause stroke if the anticoagulation is not appropriately in place. So that's what's really important in these patients. So the classifications are atrial fibrillation. We have paroxysmal, meaning it comes and goes, and it's less than 7 days long. There's persistent, that's longer than 7 days. Long-standing persistent, permanent, and then non-valvular. So those are all the different classifications for atrial fibrillation. A lot of times we'll see the paroxysmal in patients at first. Because AFib perpetuates AFib, the patients who start with paroxysmal can move to persistent, and then long-standing persistent over time. So there's several different causes of atrial fibrillation. There's the ones that cause atrial distension from chronic hypertension, mitral valve disease, cardiomyopathy. And then there's also ones that are caused by high adrenergic tone, such as sepsis or binge drinking or surgery. Some of them are very short-lived, so if someone has surgery, they might come out of surgery post-op with atrial fibrillation and then never have it again. That can certainly happen, but sometimes the atrial fibrillation does become chronic. So what are the goals of therapy of atrial fibrillation? First, it's ventricular rate control. And we want to make sure that heart rate is controlled. And that's really the #1 goal for atrial fibrillation. The main goal is a resting heart rate of less than 80 in patients who are symptomatic. So if their heart rate's over 80 and they're having symptoms of atrial fibrillation, we want to try to get that heart rate to less than 80. However, there are more lenient rate control goals, such as less than 110, in patients who are asymptomatic and their ejection fraction is preserved. So in those patients, you can be more lenient with their heart rate. Select agents, we want to select the agents to treat to treat their rate based on concomitant disease states as well as their individual response. So some patients may respond to some medications better than others. And also we want to anticoagulate them if needed. So there's 2 drug classes that we can use for ventricular control. First is beta blockers, and those I would say are probably used most often, and we prefer the beta-1 selective agents. Labetalol and carvedilol can also be used, especially if they need additional blood pressure lowering, because again, those both have the alpha blockade as well. Calcium channel blockers can be used, specifically verapamil or diltiazem, if patients are on a beta blocker and they're not able to tolerate it due to things like sexual dysfunction or fatigue, or if they have severe asthma or COPD, the calcium channel blockers are preferred. Amiodarone can be used for patients who have refractory rate control issues, who are not controlled by beta blockers or calcium channel blockers. And digoxin is another option that can be used, but it's often ineffective if it's used by itself. But it can be included in patients who have systolic heart failure or HFrEF. So Dr. Finks already talked about cardioversion, which drugs that we use for that, but I'm going to go over cardioversion, specifically the anticoagulation requirements for cardioversion. So there's 2 types of cardioversion. There's pharmacologic, which is what you use with antiarrhythmic drugs, and then there's a direct current cardioversion, which they use electricity for. And prior to any form of cardioversion, you want to confirm the absence of an atrial thrombi if the AFib has been in place for more than 48 hours. If there's a thrombi present and the patient is cardioverted, there's a 91% risk of stroke. which is pretty high. And so you want to make sure that that just does not happen. So without anticoagulation, if the AFib lasts for less than 48 hours, there's a 1% rate of thrombus. If the AFib is greater than 48 hours, there's a 15% rate of thrombus. And if the AFib is greater than 72 hours, there's a 30% rate of thrombus. So that's why the time frames really matter. And asking the patient when did they first exhibit or feel the signs of AFib is really, really important. So this table goes over when you would anticoagulate and how you would anticoagulate. I know it's pretty busy. It is in your chapter. So there's unstable AFib, patient is very, very symptomatic. You can use synchronized cardioversion with IV unfractionated heparin for those patients, but they do have a risk of thrombus. Oftentimes those patients will, if possible, they'll try to do a TEE to see if there's a thrombus present. Then there's the stable, less than 48 hours. You can see that there's two guidelines here because there's two guidelines currently out that kind of guides us on the appropriate use. You want to anticoagulate at presentation, and you want to continue throughout the cardioversion if it's less than 48 hours. If it's greater than 48 hours and they're stable, you can go ahead and initiate anticoagulation for the 3 weeks prior so that you can schedule the cardioversion 3 weeks later. And then also you can do a TEE guided approach to see if there's actually a thrombus in there. And if there is no thrombus, then you could go ahead and anticoagulate and then use the unfractionated heparin. So now let's move on to the antiarrhythmic medications. So Dr. Finks already went through these for treatment of ventricular arrhythmias, and now let's talk about them for atrial fibrillation. So again, the class 1C medications, the ones we see most often on a chronic basis, are either flecainide or propafenone. And those are considered first-line therapies in patients without structural heart disease. So again, these drugs cannot be used in patients with structural heart disease, which is very, very important. The class 3 antiarrhythmics are sotalol, dofetilide, dronedarone, and amiodarone. And these medications can be used in patients with structural heart disease, but to varying degrees. So first we have sotalol. Its efficacy is about 50 to 60%. But it does need to be renally dosed, which is very important. And it's contraindicated for a creatinine clearance less than 40 if you're using it for atrial fibrillation. You want to make sure that you're monitoring the QTC interval to make sure you're not increasing the risk of torsades. And patients do have to be admitted to the hospital for 3 days minimum, where they can, their electrolytes, their QTC, and their renal function can be monitored. There are some contraindications, particularly heart failure is one of them, as well as bradycardia or second or third degree heart block. I do get the question, can you use sotalol with other beta blockers? Because sotalol is technically a rhythm control agent, and other beta blockers like metoprolol is a rate control agent. And you can use them together, but you have to really, really pay attention to the heart rate to make sure you're not causing bradycardia. Dofetilide has similar efficacy to sotalol, about 50 to 60%. Patients also have to be admitted to the hospital with this medication for 3 days so they can be very closely monitored. This drug also needs to be renally dosed, which is very, very important to make sure patients do not get started on a higher dose than they should be, because that does increase the risk of torsades. There are also many, many, many drug interactions with this medication. They're not obscure drug interactions. They're actually medications that we see on a fairly frequent basis. So, namely hydrochlorothiazide. You can't use this with dofetilide. And so this medication always required a PharmD consult before we started it, just to make sure that the patients who were being recommended for it were actually appropriate and we weren't going to do more harm than good. Dronedarone is a medication that's structurally related to amiodarone, but it does not work very well. It has a 20 to 25% efficacy. So there are a few patients that can be maintained on dronedarone, but there just aren't very many. What they did is they took amiodarone and they took off the iodine moiety to see if they could actually make it work better or as good as amiodarone without the side effects. But what they found is it just doesn't work as well, and there's still side effects. And it also has a lot of drug interactions as well. So dronedarone is not used as much in common practice. Now, amiodarone, it's the one that works the best, hands down, efficacy between 85 and 95%. But the problem with amiodarone is it has a lot of side effects and it has a lot of drug interactions. And so if your patients are going to be on amiodarone, they have to go through a lot of monitoring. It has the electrophysiologic properties of classes 1 through 4, so calcium channel blockers, beta blockers, the class 1 and class 3. Although it does land in class 3 because that is what it's most like. Usually an oral loading dose is required, and you want to make sure that patients are not already presenting with atrial fibrillation, and then you load them because if they have a thrombi, you could actually precipitate a stroke, and that has been known to happen in cardiology clinics before. Amiodarone has a really long half-life of about 60 days. So if a patient is having adverse effects and you stop it and they say my side effects aren't going away, well, you just got to be patient because it's going to take a while for that medication to go out of their system. Also a lot of drug interactions, so those do need to be monitored. The monitoring, not only for drug interactions, but also lab work. So when I worked in the cardiology clinic, we actually had an amiodarone monitoring service, and we looked after all the patients to make sure their labs were appropriately done. And those include liver function tests, thyroid function tests, chest x-rays, pulmonary function tests. We did those at baseline, and then again if patients had pulmonary symptoms, so that if they did have pulmonary symptoms, there was something to compare. Ophthalmologic exams. Again, those side effects do go away if the medication is stopped, but you do want to make sure that patients do have their eyes examined. Blue skin, I never saw it personally, but they say it does happen. And then neurologic toxicity. A lot of patients complained of the tremors, and that can be enough to stop the medication. So this graph will help you understand when is most appropriate to use these medications. So again, it's stratified into 2 sections, no structural heart disease and structural heart disease. So if patients do not have structural heart disease, really you have the gamut of which medications that you can use. You can see the 5 there in the bubble to the left, and then if those fail, you can always use amiodarone as a last resort. And then for patients who do have structural heart disease, it's divided into CAD, or heart failure. Patients who have CAD can either be on dofetilide, dronedarone, or sotawall. Patients with heart failure can either be on amiodarone or dofetilide. And again, amiodarone is the last line agent for this side of the algorithm as well. Okay, so let's move on to anticoagulation. So for patients who have chronic atrial fibrillation, how do we decide who we anticoagulate and who we don't? Because we certainly don't want to anticoagulate people who do not have a reason to be anticoagulated, because we're just going to increase their risk of bleeding and not really have any benefit. So we used to use the CHADS-2 scoring system, but with the 2014 atrial fibrillation guidelines, they actually said the CHADS-VAS score is the one that's preferred. And that's because for patients who have lower risk, who have a score of 0 to 1, it was really unclear on which patients of those you'd actually anticoagulate or not. And so this gives us a little bit more specificity for those patients who are at lower risk. And you can see there that most of the scoring items have a score of 1, but if you're over the age of 75, you get 2 points, or if you have a prior TIA, stroke, or thromboembolism, you also get a score of 2. And all female patients who have chronic atrial fibrillation, they get a score of 1. And so I've had people ask me, so any woman who has atrial fibrillation should be anticoagulated? Well, that goes to our next slide. Well, I'll go here and then I'll go back for a moment. So this is what tells us how they're scoring, if they should be anticoagulated or not. So if someone has a score of 0, it's reasonable to admit antithrombotic therapy. So that would only be men, right? Because all women at least have a score of 1. If a CHADS-VAS score is 1, you can choose between 3 different options. You can say no antithrombotic therapy, you can say you need to oral anticoagulate them, or you can choose aspirin. And so for the patients who ask me about women, so if women only have that risk factor, they're young and they're healthy, then you could choose to not anticoagulate them, especially if they're at high bleeding risk or if they're especially active. But if those women convert over to 2, then you definitely want to anticoagulate them, meaning they have another risk factor. So that's something that's really important to remember. So this graphic goes over what the adjusted stroke risk is for someone with a CHADS-VAS score. So and the middle column said, in the study that looked at the CHADS-VAS score, how many patients were in that cohort. So you can see for patients with CHADS VAS score of 0, there is one patient. That patient did not have a stroke, so they say the risk is 0%. If you look at other literature, some people say the risk is about 0.4 or 0.5%. So I would say just because you have a score of 0 does not mean you'll absolutely never have a stroke, but you may not have a stroke caused by atrial fibrillation. When their score was 1, there was about 400 patients in it, and their risk was 1.3%. So you can tell patients when you're trying to make the decision with them what you're going to do, how to treat them. You can say your stroke risk is about 1%. Here's our 3 options. But for anyone who has a CHADS VAS score of 2 or greater, it's very important to anticoagulate them. And you can see the higher their score is, the higher their risk is of having a stroke. The anomaly there is a CHADS VAS score of 8. And you can see here that the risk is 6. So it went 6, 9, 9, 6, 15. How does that happen? So it just goes to show us that when we're studying patients and we're looking at real life events, sometimes things don't happen exactly like we would expect. And also, it's not an exact science when we're measuring patients and their event rates. We had 82 people in this, and they just happened to not have as many strokes as anticipated. But in general, it's important to remember that the higher the score, the more likely you're going to see them have a stroke, and the more important it is to get them anticoagulated. So now we have Paul. Remember Paul. He's the guy that works all the time, 60 hours a week. He finally came in for that fluttering feeling in his chest. So what should we do for him? Should we begin digoxin? Should we begin diltiazem? Should we begin warfarin? Or should we begin dabigatran? So I see green and I see yellow, mostly out there. A few other colors, but mostly green and yellow. So I agree he needs to be anticoagulated. So let's go back to his case. So he has hypertension, so that's 1 point, right? He has a TIA, that's 2 points. So he's already at 3, right? So he definitely needs to be anticoagulated. And so why would I choose dabigatran over warfarin for this patient? So if he's working 60 hours a week, and he only comes in to get his fluttering figured out several weeks later, do you think he's going to come in once a week for INR checks? Probably not. His labs are normal. He's got good renal function, and so he could probably take one of the direct oral anticoagulant medications or the DOACs. So let's talk about those. So dabigatran is the one that's been out on the market the longest. It's a direct thrombin inhibitor. And it is dosed just like the rest of them. You have to be very careful in patients with renal insufficiency. So for patients who have a creatinine clearance less than 15, you have to avoid these medications. But for patients who have a creatinine clearance greater than 30, you can treat 150 milligrams twice a day. And if they have a creatinine clearance between 15 and 30, the dose is 75 milligrams twice a day. There are specific instructions when you convert these medications to or from warfarin. And you can see it's largely dependent on their renal function, on how long the patient should be on warfarin before you're able to discontinue the dabigatran. And there's also instructions on going to and from parenteral anticoagulation, as well as converting from warfarin to dabigatran. So do review that information in case that is asked. Rivaroxaban was the next one to hit the market. It's a direct 10A inhibitor. And again, it's dosed on renal function. It's only dosed once a day versus twice a day that we saw with dabigatran. And there's also instructions for that when you're converting from or to warfarin. Basically, you want to discontinue warfarin and initiate rivaroxaban once the INR is below 3. Apixaban was the next one to hit the market. It is also a 10A inhibitor, just like rivaroxaban. It's also renally dosed, but it's dosed a little differently. It's not just dosed based on creatinine clearance. There's 3 characteristics that you have to look at for these patients. If they're age over 80, if their body weight is less than 60 kilograms, or their serum creatinine is 1.5 or greater. If they meet 2 of 3 of these criteria, then the dose is reduced from 5 milligrams twice a day to 2.5 milligrams twice a day. So this medication, like dabigatran, is dosed twice a day. Also, this medication you can convert to apixaban once the INR is less than 2 if a patient's taking warfarin. Edoxaban is the newest one. It recently hit the market just a few months ago. It is also a 10A inhibitor, and it is also dosed based on renal function. Although the very interesting thing about edoxaban is that if your creatinine clearance is greater than 95, so you have excellent kidney function, you should not use this medication because it does not work as well. So that's a very interesting caveat for this medication. So this graph here shows a lot of the different characteristics for the DOAC therapy. So just a little bit of a side note on what the naming of this system are. We used to call them NOACs, novel oral anticoagulant medications. Then some people called them SOACs, or target-specific oral anticoagulants. In the literature, it's also DOACs, direct oral anticoagulants. A lot of the guidelines now are calling for one name, for goodness sakes. And so I think the consensus is going to fall on DOACs, although certainly is not universally accepted yet, so we'll definitely see what happens. As you can see, the mechanism of action, dabigatran is factor 2 or thrombin inhibitor. The other three are all 10A inhibitors. The peak is very similar between the four, between 1 and 4 hours. The half-life is also similar, which is very interesting since some of them are dosed twice a day and some of them are dosed once a day. And they all have varying degrees of renal elimination. And so based on these factors, you can use these to decide which is the most appropriate agent for your patient. So warfarin, we're very familiar with warfarin. It's been out since the 1950s. It inhibits the vitamin K dependent clotting factors, and its half-life depends on the several different factors that it affects. It usually takes about 5 days in order for it to reach maximal effect, so do keep that in mind when you're changing the doses. And usually when you change a dose, you change it by 5 to 20% based on the weekly cumulative dose. So now we have Harry. He's a 67-year-old man. He has hypertension and mitral valve insufficiency. He's had AFib for the last 4 years, so you've been following him for quite some time. He's on ramipril, sotalol, digoxin, and warfarin. But today he's complaining of shortness of breath and palpitations and some lower extremity edema. His blood pressure and heart rate are there, and his INR is 2.8, so he's in therapeutic range. His EKG is showing atrial fibrillation, but his echo is showing an ejection fraction of 35 to 40% and moderate mitral valve insufficiency. So what's the most appropriate rhythm control strategy to manage his atrial fibrillation? So should we stop his sotalol and begin metoprolol succinate? Should we stop his sotalol and begin dronedarone? Should we stop his sotalol and begin amiodarone? Or should we continue his sotalol and then add metoprolol on top of that? What do you guys think? So we have some greens, we have some blues, we have some yellows. Okay, we have the rainbow again. All right, so let's go into this. So heart failure and atrial fibrillation, again, when those two concomitant disease states go together, they can be very hard to control because when patients have heart failure, they're very intolerant to atrial fibrillation because they have the fluttering in their heart is already kind of maxed out, and they just don't feel very well when they have both. And the biggest issue is, do we use rate or rhythm control in these symptomatic patients? So they don't feel good, they want to feel good, they want to stay out of the hospital. How do we treat them? And it's really hard to differentiate if their symptoms are coming from their heart failure or if their symptoms are coming from their atrial fibrillation, because a lot of the symptoms overlap. And rate control is actually preferred if we can get their symptoms under control with rate control, because rhythm control can increase the risk of hospitalization, and it can lead to a lot of side effects, and we just talked about some of those side effects. So we want to optimize their heart failure therapy so we can get their pumping as best as we can, and we want to make sure we maximize their rate control therapies as best as we can. And then we'll consider antiarrhythmic therapy if they still continue to have those symptoms. And like we said previously, only dofetilide and amiodarone have been proven safe in this population because some of the other agents, particularly the 1Cs, have been shown to increase mortality in these patients. And the rate control options include beta blocker. Obviously, when you use metoprolol succinate or carvedilol, you can use digoxin. It might help with their symptoms. And of course, you want to avoid the non-dihydropyridine calcium channel blockers because they have negative inotropic effects. So remember our patient Harry, he's on ramipril, sotalol, and digoxin. He has atrial fibrillation and he has this new diagnosis of heart failure. and he's symptomatic. So what should we do for him? Should we stop his sotalol and begin metoprolol? Should we discontinue his sotalol and begin dronedarone? No, we can't use that drug, right? We can't use dronedarone in heart failure. Should we discontinue his sotalol and begin amiodarone? I say yes. So amiodarone can be used in these patients. You can use it in heart failure. It can be very, very effective. So we would just need to monitor him very closely. We could continue the sotalol and begin metoprolol, but his heart rate was actually well controlled, so we probably don't need that additional beta blocker therapy. What he really needs is his rhythm controlled so that he doesn't have so much symptoms. And so amiodarone is probably appropriate for this patient. Okay, so the key points for atrial fibrillation. So for patients who have a CHA2DS2-VASc of 2 or greater, you want to make sure that anticoagulation is started. And if they have a score of 1, you have 3 options: no therapy, anticoagulation, or aspirin. For patients who have an atrial fibrillation of greater than 48 hours in duration, you want to make sure that they're appropriately anticoagulated. For rate control, you can use either beta blockers or non-dihydropyridine calcium channel blockers. For rhythm control, you want to choose the agent based on their concomitant disease states. And anticoagulants, you want to make sure you pay attention to their renal function if they're using DOAC therapy. And you also want to make sure that you are treating them according to any drug interactions that might be present, especially with warfarin. Okay, now let's move on to hypertension. Hypertension is my favorite topic. It's the one that I've talked about the most professionally, and so I'm a little partial. So we have Dave. He comes to your clinic. He's a hilarious 50-year-old guy. He always has a joke for me every time I see him. But he was recently discharged from the hospital, status post-MI. His past medical history includes hypertension, and he's treated with hydrochlorothiazide. Luckily, post-MI, his ejection fraction remains greater than 60%, so that's lucky for him. But his blood pressure is at 150/94, and his heart rate is 80. So what's the most appropriate way to manage his hypertension? So should we stop the hydrochlorothiazide and add diltiazem? Should we continue hydrochlorothiazide and add metoprolol? Should we discontinue hydrochlorothiazide and add losartan? Or should we continue hydrochlorothiazide and add losartan? So I see some D's. A B. All right, it's yellow and red. Okay. So hypertension is when blood pressures are greater than 140/90, and it is the most chronic disease state in the United States. It affects about 78 million Americans, and it's a major modifiable risk factor for every cardiovascular disease. But unfortunately, only about 47% of patients are controlled in the United States. So you have all these drugs, all this expertise, but about half of people are uncontrolled. There's something wrong with that equation. Because the benefits of treating hypertension are huge. It can decrease the risk of stroke by 40%, decrease MI by 25%, and decrease heart failure by 50%. So again, here's these lifestyle modifications that we heard about for patients with heart failure: weight reduction, decreasing sodium intake, physical activity, and moderation of alcohol. When you look at these modifications, they can reduce blood pressure by themselves. You can see in the right-hand column they've actually been shown to have some blood pressure reduction. And then if they can do more than one of these things, you'll actually see more of a blood pressure reduction. So for patients who are otherwise healthy and they have moderate increases in their blood pressure, you can try lifestyle modification first, because if patients are really serious about it, they will see a decrease in their blood pressure. So the blood pressure goals, these are the classifications that were listed in JNC 7. You might be like, why are you referring to JNC 7? That was like a long time ago. And that's because the recent publication that was written by the JNC 8 panel wasn't really JNC 8 per se, because the National Institute of Health actually turned over the writing of the blood pressure guidelines to ACC/AHA. And so the people who wrote the JNC 8, the original panel, they went ahead and published their guidelines, but it's not really considered a national guideline. But they do have some good recommendations because it is based on evidence-based therapy. So that's why I went back to JNC 7, because in that publication that was published in JAMA, there was not a classification of blood pressure. Really what that document did was answer some very specific questions about blood pressure management. So here you can see the blood pressure goals, stage 1 and stage 2. the numbers that you'll probably need to know. So for the patient population, for the first one, there is an error on the slide. I was going to change it when I put my slides together, but I thought if I did, I'd forget to tell you. So the blood pressure goal now for patients with diabetes is less than 140/90, not 80. So the American Diabetes Association, they actually changed their blood pressure goals to align with the JNC8 panel recommendations in January of 2015. And so please do change that. And the reason they did that is because they said that there really was there's not enough evidence to support a lower blood pressure goal for diastolic. However, patients with diabetes, they can consider lower blood pressure targets if they're healthy and they can otherwise tolerate it and the medication burden is not too high. For the general population, the next line there you can see are the ones that came from the JNC8 panel. For patients who are over 60 years of age, they say their blood pressure can be less than 150/90. That's a big change that came out of that document. And then they said for patients who are under 60 years of age, their blood pressure goal should be less than 140/90. So the less than 150/90 is a very contested goal. A lot of the other guidelines say that you should not increase the goal until patients over 80 years of age, and that's based on the HIVIT trial. So that's why you'll see in the next line, for adults age 18 to 80, the goal is less than 140/90. So if you see a patient between 60 and 80 years of age, just understand that there is some controversy on what their blood pressure goal should be. A lot of experts are saying that if you can get them to less than 140 easily without side effects, you could actually decrease the risk of cardiovascular events without undue medication burden. So that's kind of where we're standing now. And then, very exciting, we just had the SPRINT trial come out, and that's going to give us more information on what the appropriate blood pressure goal should be in these patients. So the SPRINT trial was an NIH-funded medication trial in more than 9,300 patients who are aged 50 years or older with at least one cardiovascular risk factor or with renal disease, but they did not have diabetes. And the reason why they excluded patients with diabetes is because we already had the ACCORD trial. And so with the ACCORD trial, they thought the answer was already given for patients with diabetes. And it's important to note in the SPRINT trial that about 25% of patients were 75 years of age or older. So not a small amount of them were over 75 years of age. The patients were randomized to either the intensive blood pressure arm or the conventional blood pressure arm, so they're less than 120 or less than 40, and they had a primary composite outcome of MI, other ACS, stroke, heart failure, or death. And it was actually stopped early because the results were so impressive. So during the 3.6 follow-up years, the intensive group had a mean systolic blood pressure of 121, and they needed about 3 drugs to treat their blood pressure. And the standard group had a mean blood pressure of 135 and needed about 2 medications to treat their blood pressure. And the primary composite income was statistically significant for the intensive group. And compared with the conventional arm, the intensive arm had reductions in heart failure, cardiovascular events, death from cardiovascular causes, and all-cause mortality. And so while this trial is very new, it was just published last fall, obviously not incorporated into any guidelines yet, it'll be very interesting to see where the goal blood pressure is going to be for elderly patients based on this information. The ACC/AHA have promised us that we're going to have a blood pressure guideline by the end of this year. For people who were waiting for JNC8, know how that goes sometimes. So we'll definitely see if we can get more guidance coming. For patients who have CKD, for patients who are over 18, if they have diabetes or not, but their urine albumin excretion is less than 30 milligrams per day or for 24 hours, the blood pressure goal is less than 140/90. However, patients who have an albumin excretion of greater than 30, they recommend a blood pressure goal of less than 130/80. So this patient population, patients who have macroalbuminuria or excretion of greater than 30 milligrams per 24 hours, they're the only people who have this lower blood pressure goal right now as we sit. So it'll be interesting to see if more patients are added to that. There are some people that were speculating last weekend at ACC that more people would have this blood pressure goal based on SPRINT, but we'll see what happens. And then for patients who have HFpEF or HFrEF, there really isn't a goal. Honestly, most people say the lower the better. Some people say 120/80. But a lot of these patients, like I said earlier, are are really just fighting hypotension because they're on so many drugs that can lower blood pressure. But if they do have hypertension, it's very important to treat it because that's very stressful to their heart. So do keep that in mind. So here's an algorithm that is in the ASH-ish guidelines, American Society of Hypertension, International Society of Hypertension. You can see that patients who are of African American descent, the preferred medications are calcium channel blockers or thiazide diuretics. That's because ACE inhibitors and ARBs don't lower blood pressure in those patients quite as well, but that doesn't mean that you cannot use them as adjunctive therapy because they can still get benefit from them. They just don't have quite the bang for the buck in blood pressure lowering. In patients who are not of African American descent, they stratified them according to age, and there's really not a lot of evidence for that. And they've actually came back and said, really you can take age out of the equation. You can either use ACE inhibitors or ARBs or thiazide diuretics for first-line therapy in most patients. So do keep that in mind. Those are your 4 first-line agents for patients not of African American descent. Of course, don't use ACE inhibitors and ARBs together. And then you want to assess for compelling indications. That's really important. So for patients with diabetes, most guidelines say you want to include ACE inhibitor or ARB for those patients. And same with patients with CKD or history of stroke. For patients with coronary artery disease, really important that they're on beta blocker therapy and ACE inhibitor therapy. So they have CVD and hypertension. Those 2 medications should be included. Patients with HFrEF, we know they're on many medications that can lower blood pressure, as well as patients with HFpEF. So now we have Dave again. Remember our really funny guy who comes in, but he just had an MI. He's on hydrochlorothiazide and his blood pressure is still high. So what should he be taking? Should we continue his hydrochlorothiazide or should we stop it? What should we add? What should we add on? So we still have some D's. Okay, so what did he just get out of the hospital with? An MI. Is he on beta blocker? Should he be? Right. So what's the right answer? B. So let's do the red. Okay, so really important. So a lot of times people get bogged down with race or age or a lot of other things, and they forget sometimes the most basic components. So this is a great example of how a question can trick you, right? Because you're thinking of so many things, and you forgot he just came from the hospital with an MI, right? So really, really important to pay attention to the details. Let's talk about monitoring therapy, and then we'll move on to dyslipidemia in just a few slides. So if you've adjusted somebody's hypertension therapy, you want to return in 4 weeks to assess their efficacy, make sure it's working well for them, determine if you need to add on another medication or titrate their dose. You may have a patient follow up sooner if their blood pressure is particularly worrisome. So their blood pressure is really low or their blood pressure is really high, you might want to see them sooner. And if there's an inadequate response with the first drug and no compelling indication exists, you want to initiate drug therapy from a different class. So you want to optimize it. So there's actually 2 schools of thought. You can either use 2 low doses of different medications from a different class, or you can optimize one medication and start another. Generally what I do, because patients don't like to take lots of medications and they don't like to pay for lots of medications, I'll start one and optimize it, then I'll add a second, or I'll use combination therapy so there's more than one medication in a tablet. A lot of patients like that. The downside to that is usually the combination medication is hydrochlorothiazide. That is not the best thiazide. Chlorthalidone definitely is. Something like 95% of thiazides used in the United States is hydrochlorothiazide. So I think our blood pressures would be really much better controlled if we did use chlorthalidone. It has much better CVD lowering effect, or CVD outcomes data associated with it. This was a big topic at ACC last weekend as well. So if you see a patient on hydrochlorothiazide, their blood pressure is not well controlled, switch them to chlorthalidone and see what happens. They may not need any extra medications as far as numbers go, but their blood pressure might be better controlled. Just really make sure you monitor their electrolytes because it can cause a depletion of electrolytes a little bit more than hydrochlorothiazide. That's probably because it works better. So just keep that in mind. Now we have Terry. She's a 45-year-old Caucasian woman. She has type 2 diabetes and she has macroalbuminuria. Her blood pressure is 138/88, and her blood pressure at last visit was 136/85. So her blood pressure is pretty stable. What's the most appropriate approach to treat her blood pressure? lifestyle modification and amlodipine, lifestyle modification and lisinopril, or lifestyle modification and atenolol. So we have greens and blues. I'm going to go with the greens because what concomitant disease state does she have? Diabetes, right? And we know from that chart that patients with diabetes, most of them should be on an ACE inhibitor. She also has macroalbuminuria. So what's her blood pressure goal? Yeah, less than 130/80. So she's not at blood pressure goal. So she definitely needs a medication. So good job, guys. So hypertension key points. We want to treat to a target blood pressure, make sure they're at their appropriate goal. We want to address lifestyle modifications. The first line medications, if no concomitant disease states exist, are ACE inhibitors or ARBs, as well as thiazide diuretics, use chlorthalidone if you can, and calcium channel blockers. If patients are African American, either use calcium channel blockers or thiazide diuretics. If they have concomitant disease states, that should guide therapy, such as diabetes, CKD, heart failure, CAD, or stroke or TIA. Blood pressure in the elderly, if patient's blood pressure is greater than 160/100, you can consider starting 2 medications at once because they'll probably need that. And if patients are elderly, you want to start low, go slow, and also evaluate how healthy they are. That will also help you determine what the appropriate blood pressure should be. If they're frail and elderly, maybe give them a little bit more space, increase their goal. If they are very fit and they run marathons like they do in Denver, then I would give them probably a lower blood pressure goal. Let's talk about CVD risk assessment. So ASCVD risk assessment was actually changed in 2013 when those guidelines came out. And for patients who are aged 20 to 79 years old, you want to address or evaluate ASCVD risk assessment at least every 4 to 6 years. For patients who are 20 to 39, you just assess their risk factors. And for patients who are 40 to 79, use the pooled cohort equation, and that's available at these websites. When you do go on those websites, there's a table that you actually put in the patient's values, and you can see there in blue where you actually input those. And they take into account the risk factors for sex, age, race, total cholesterol, HDL, systolic blood pressure. If they're treated for high blood pressure, they have diabetes or smoking. And you can see there's where the units are, so that would be what an acceptable answer would be, what the acceptable range of values are. And on the far right is the optimal values. So if a patient has optimal values, that means that their 10-year risk of having ASCVD is actually lower than the general population. So that's what those optimal values are. And for the example that I put in there, this is what this gentleman's ASCVD risk is. So within 10 years, his risk of having an ASCVD event is about 15%, which is pretty darn high. But if he had the same age and gender and race, and his risk factors were optimal, all those ones that are on the right-hand column, his risk could only be 2.2%. So a lot of times this speaks volumes to patients. Say, hey, if you get your cholesterol controlled, if you stop smoking, we can definitely decrease your risk, and you can show them that number. And his lifetime risk of having an ASCVD event at some point is almost 70%, which is pretty huge and can also speak very loudly to patients that they need to do something to modify their risk. So let's talk about dyslipidemia and some of the other ways that we can modify risk beyond hypertension. So again, we have the recommendations of lifestyle modification. Again, very, very important. But beyond those, we also want to initiate statin in secondary and primary prevention patients at moderate to high intensity dose in 4 very specific groups. We no longer base therapy on LDL or non-HDL goals, although that is still up for debate and was, again, a very big topic at ACC last weekend. And so it'll be really interesting to see where we go with that. There was a guideline that was just issued for non-statin therapy that the ACC-AHA issued. They were talking about considering goals of less than 100 or considering goals of less than 70 in certain patient populations. So it might come back again, but for now, the guidelines are still saying we're not targeting a goal. We're looking at an intensity of statin therapy. So routine initiation of statin therapy is not recommended for patients just because they have heart failure. If they have ischemic heart disease, then we would start it, but not just for heart failure specifically. Or we're not going to start it if they're on hemodialysis, although if they're already on it and then they begin hemodialysis, they may continue it. And then eligible patients are now placed into one of 4 major statin groups. So this would be really important to remember as well. So the 4 major statin benefit groups are patients with ASCVD. They have a history of MI, they have a history of stroke, they have a history of PAD, anything that has vascular, cardiovascular disease. Also individuals who are primary prevention and they have an LDL over 190. That means they probably have some familial component to their hypercholesterolemia, and so they need to be treated because they're at a very high risk of having ASCVD. Patients who have diabetes who are age 40 to 75, who have an LDL between 70 and 190, but do not have ASCVD, we want to treat those patients with a statin. Or patients who are primary prevention, they have an LDL between 70 and 190, and their 10-year risk, using the calculator we just talked about, was 7.5% or greater. Those patients also can benefit from statins. So what do you mean, you might say, what do you mean by the potency of a statin? So this table will show you exactly what potency each dose of a statin is. So you can see that we only have 4 statins that are high intensity, 4 doses. So atorvastatin 40 or 80, or rosuvastatin 20 or 40. So those are the only 4 we have with high intensity. So that is pretty easy to memorize. And then for the ones in orange, those are the ones that are moderate intensity. So we expect those to lower LDL anywhere between 30 and 50%. And so you can see we have quite a few options there. And then for the low intensity statins, we don't have any really formal recommendations for those. And generally we'll reserve those statin doses for patients who cannot tolerate higher intensity statin doses. So this graph goes through, it's from the guidelines, it goes through how you treat patients with what the appropriate statin intensity is based on if they have ASCVD, high LDL, diabetes, or if they're primary prevention with a high pooled cohort risk. And you can see it's modified between high intensity statin and moderate intensity statin. So I pulled these out so it's a little bit easier to read. So just remember, if someone has ASCVD and they're younger than 75, it's a high intensity dose. If they have ASCVD and they're over age 75, so more elderly patients, a moderate intensity is what's recommended. For patients who have the familial hypercholesterolemia, whose LDL is greater than 190, high intensity is recommended. A lot of these patients have MIs at a very young age, and so we want to make sure that we treat them aggressively. For patients who have no clinical ASCVD or diabetes, but they have a risk of greater than 7.5%, you get a little bit of clinical decision-making and shared decision-making with the patient. You can choose either moderate or high-intensity statin, depending on their particular situation. Let's say they have a very strong family history, or they have a high hsCRP that might push you over to choosing a high-intensity statin, but this one you can individualize to the patient. And then for patients with diabetes who are age 40 to 75 and their LDLs between 70 and 190, but no ASCVD, if their risk is greater than 7.5, you want to do a high-intensity statin. And if their risk is less than 7.5, you want to do a moderate-intensity statin. So those are the guidelines those are from the ACC-AHA guidelines. And then if you look at the ADA, their recommendations are very similar. So for patients with diabetes, a high-intensity statin should be added if they already have overt CVD, or they're between 40 and 75 and they have one of those following risk factors. And then they give you some clinical decision-making for patients with diabetes. You can either choose moderate or high intensity if they're younger than 40 or older than 75 with additional risk factors. And then a moderate intensity statin would be recommended if they're between 40 and 75 without any additional risk factors, or they're over 75 without any additional risk factors. So for most of these patients, they will follow both guidelines regardless, but there are some outliers that you might see that would fit one guideline but not another. All right, so now we have Mary. She's a 63-year-old white woman. She's tried 6 months of diet and exercise for her dyslipidemia. She has a history of gout, non-ischemic heart failure, diet-controlled diabetes, asthma, 15-pack year history of tobacco, but she stopped, but she continues to drink beer every day. We don't know her family history, but she is on an albuterol inhaler, lisinopril, furosemide, and Tums every day, probably because of the beer. Her vital signs are there, blood pressure and heart rate. You can see her labs, her LDL is 101, and her pooled cohort equation is 7.1%. So what's the most appropriate step for Mary? Should we initiate a low-intensity statin because of her 10-year risk is less than 7.5? Moderate intensity because her risk is less than 7.5, high intensity, or she can discontinue lifestyle? And we're going to answer this one right now since we're running out of time. So what do you guys think? Moderate or high? Continue just lifestyle? So I see some B's. So she's got diabetes, right? Her risk is less than 7.5%, 7.1, so a moderate intensity statin would be appropriate for her. But you could also let her know that she does have diabetes. Her risk is close to 7.5. She could consider a high intensity if you wanted to. But just going by the guidelines alone, a moderate intensity statin would be appropriate for her. Treatment of high triglycerides, not a lot you need to know, except if they're over 500, we would want to treat them to decrease the risk of pancreatitis. Lifestyle modification is really the cornerstone here. Treating with fibrates, you don't really want to do that if they're in combination with a statin because of drug interactions. And so, again, lifestyle is a cornerstone for treating high triglycerides. If they're very high, you could consider initiating drug therapy, but we'd have to do that on a very individualized basis. Also, you want to look for medications that can increase lipids, because if patients are on things like corticosteroids or cyclosporin and they have high lipids, that can help you determine if you can modify their other therapy or if you actually just need to treat them because they can't use any other drugs. So statins obviously are our cornerstone. They've been shown to reduce mortality, reduce coronary vascular events, and reduce stroke and total mortality. So it's really important that when you're thinking about treating these patients, statins are where you go. The risk of myopathy and myalgias are real for these patients. So about 10% of patients do see myalgias. A lot of times they're not substantiated with increases in CK. And so you can try lower doses, or you can try hydrophilic statins instead of lipophilic statins, which may be a little bit better tolerated for some patients. Rhabdomyolysis is a real side effect for a lot of patients. And so if patients are experiencing very severe muscle dysfunction, you want to make sure you are checking a CK to make sure they don't have rhabdomyolysis. If they do have it and it goes undetected, they can get very sick, they can die, they can get renal dysfunction that's permanent. So just be sure that you take note of these. The good thing though is if you do catch it and you do stop the statin, then it's reversible. So the factors that include or increase the risk of statin-induced myopathy, age, female sex, renal insufficiency, as well as statin properties such as really high doses or lipophilicity. So those include statins like simvastatin, lovastatin. Atorvastatin is kind of one that's in between. If patients have renal dysfunction, you want to make sure that their statin dose is appropriate. So drugs like atorvastatin, there really isn't a restriction on how high the dose can be, but other medications, particularly simvastatin, which is no longer available in the 80 milligram dose unless a patient's been taking it for years, then you want to make sure that you're paying attention to their being appropriately dosed for their renal function. So according to the ACC-AHA guidelines, which is best describes moderate intensity statin dose? Is it pravastatin 20, lovastatin 20, atorvastatin 40, or rosuvastatin 10? Right, I see mostly yellow, and I'd agree. So it's really important that you have these in your head so that you know when you're answering these questions, you can pick the right statin. So I'm just going to briefly go over some non-statin therapy medications. So bile acid sequestrants, they've been around for a really long time. They're hard for a lot of patients to take because it's a lot of bulk. It's either in powder or in tablets. It can also cause constipation, and so sometimes it's even used in the treatment of patients with diarrhea. So they can lead to a lot of GI distress. We don't use those very often, except maybe in a last-line patient that can't take anything else. Niacin has been used for years to not only lower LDL, but also increase HDL. There's been some recent outcomes data to come with niacin to show that it really doesn't affect cardiovascular morbidity or mortality. And so some people might continue to use it as an add-on therapy to statins. We want to make sure you're monitoring patients for myalgias if you do that. Really, I just see these in clinics that are still focusing on LDL goal or patients who are at very high risk. So do keep that in mind. We want to make sure we monitor for liver disease as well. Again, fibrates are usually used just in patients with high triglycerides. Do use in caution if combination with statin therapy. They do have side effects, and with their outcomes trials really haven't panned out either. So we're not really starting these to decrease morbidity and mortality. Ezetimibe was shown recently in the Improve It trial to decrease a composite endpoint by about 2%. And so the LDL was 70 in one arm, in the simvastatin only arm, and it was about 50, I think it was about 60 in the other arm, and there was a decrease in the cardiovascular events. And so the question was it adding ezetimibe or was it the lower LDL? So it kind of initiated the debate again on if it's how low the LDL is or if it's actually the therapy that you use. And so in the most recent guideline that came out from ACC-AHA, they said you can add ezetimibe to patients whose LDL has not responded adequately to statin therapy in patients who are at very high risk. Omega-3 fatty acids can be useful in the treatment of high triglycerides, particularly in patients who are already on statin therapy. And that's because they don't have drug interactions and they're not going to adversely affect patients who are already on statin therapy. They can lower triglycerides quite well, especially using higher doses. Sometimes they can be hard to tolerate on a GI basis, so you'll have to work really closely with your patients. And they're not only available over the counter, but they're also available in some prescription products as well. There's a couple of medications, Juxtapid and Momepersen, that are available. Both medications have been shown to lower LDL. We don't really have outcomes data on either of these medications. They do have a lot of adverse effects, and namely on the liver, and so they have not really been used much, and the uptake has been very small. The new medications, the PCSK9 inhibitors, evolocumab and alirocumab, those have no outcome data still, but they have been shown to lower LDL very well by between 50 and 60%. So it'll be very interesting to see when the outcome data is available. I believe it's due out next year if they are able to show a decrease in cardiovascular events. And so these are a very hot topic right now, mostly because they're quite expensive and they're only available through subcutaneous injection, either once every 2 weeks or once a month. And so it'll be really interesting to see how these are incorporated into the new guidelines once the outcome data is available. And they're only indicated for either patients with familial hypercholesterolemia or patients with ASCVD. So we'll have to stay tuned on these medications. So the key points for dyslipidemia, we no longer treat to an LDL goal, although that is subject to change in the future. Recommend lifestyle modification. Initiate, monitor high-intensity statins in patients who fall in benefit groups. Reserve non-statin therapies for when it's clearly necessary. And look for secondary causes when the LDL is greater than 190 or the triglycerides are greater than 500. And I just want to thank you guys all for your attention.